Pessoal, então, começando aqui a segunda parte da reunião, bom dia a todos e vamos lá. Vou mudar aqui para o inglês devido a nossos convidados internacionais. So, good morning, everyone. Today there's going to be a special meeting where we'll talk about complex cases, challenging surgeries. I believe it's a topic of interest of many because it's interesting to see what others will do in that situation. I now thank our presenters today, Dr. Arthur Vandenberg and Dr. Caroline Maya from the Medical University of South Carolina. Thank you very much for your participation. And today we have our fellow colleagues from abroad watching us today. That's why we're talking in English. So without further ado,
ladies first.
Ladies first. Okay. Good. So good morning, everybody. Bom dia. Bom ver os amigos aqui, o Maurício, Elaine. Olha quanta gente que está aqui. Que legal. Let me start here, and please keep me 15 minutes because our fellow also has 2 cases to present. So I'm going to try to share my screen here. If everyone has any questions or even something that you want to ask in Portuguese, I'm happy to translate. So we're going to talk about some challenging cases, happy to discuss here. Just want to introduce our cornea and refractive team here at the Storm Eye. This is Dr. Fernandez. She's one of the attendings. James, he's on the top right. He's our clinical fellow. He's doing a surgical fellowship. And Eduardo actually is from Brazil. He lives here. His parents are from here, and he's our research fellow at the moment. He's actually pre-med, but he's doing an amazing job here. And Joey is the resident. So they're all in the call here. And then James is going to present some cases. They're very happy to meet you all, and hopefully we can all come and visit, hopefully soon. That would be fantastic. Well, so we're going to present some complicated surgeries here. This is a 65-year-old male that had a complicated cataract surgery in the left eye. And he had severe photophobia and monocular diplopia. Vision was counting fingers, normal pressure, and normal dilated exam. So let me start here with this picture. This is what we're dealing with. So at this point, this patient was basically aphakic, and this was the iris. And just maybe briefly, let me see, this is the video. Let me go back here a little bit, for the ones that sees this cases more often, aphakia with this iris, options, and what would you consider? Don't know, Arthur, if you want to comment, or...
Is this a dilated pupil?
No, this was a traumatic. Yes, this pupil was fixed and had iris atrophy.
This sphincter doesn't work.
That is correct.
Okay.
How old is she, Carol?
65. 65.
No cataract?
Oh, had surgery in the aphakic.
Aphakic, okay. I think suturing this iris, a pupil cerclage or a simple suture, it's fine too.
Yeah, no, it's all a good option. Yes, I think, we consider, I think for this cases, and I'll show the video, what I do sometimes during surgery, I see how much of tissue I have, to suture. But we're going to talk a little bit about one option that we have here. That is the artificial iris implant. I'm going to show the surgery, and then we can go through some slides here. Is the video playing okay? Yeah. So, okay. So for this case, so what we plan, I need to implant 2 things, IOL and an artificial iris. So yeah, James was with me, helping me here in this case, our fellow, and I'm creating some tunnels. You know, I think for secondary IOLs, we can do Yamani, right? Or you can suture, but I think for this cases, when I'm planning on doing an artificial iris, I like to suture the lens. Still, I think it's more stable. So in this case, again, I'm creating the sclerotomies and just passing this Gore-Tex suture from both sides. And this is just a MX60 Invista lens. I'm a lente MX60, a Invista. Yeah, and then it's easy. You can just fold. And then again, I'm just using a small incision with usually 4 milímetros, 4 milímetros ali de distância entre as duas suturas, because it's easier for centration, right? So then again,
you create a sulcus for the Gore-Tex, right?
I'm creating a sulcus for the Gore-Tex, yes. So the artificial iris implant, we're going to talk a little bit about the artificial iris implant, but here just a surgical technique. One thing that I do to make that makes my life much easier, I pre-suture with Gore-Tex. Eu passo o ponto antes, e aí uso o injetor, and then I use the injector. So this is the J&J injector, the old injector for that sensor lens. The name is AMO Silver Series, because then you can just fold this implant inside the injector, right? So then that will go through a small incision. So that's what I'm doing there now. And as you can see here, right, it will be much easier to implant. Of course, a lot of viscoelastic to protect the cornea. There's a lot of manipulation there, and then you can inject the artificial iris. So even if you have a sulcus to place this artificial iris, I like to suture. Eu sempre suturo, porque tem casos descritos de UG syndrome, uveitis glaucoma hyphema. So I always suture these cases. And then here, you know, we just want to pass all the sutures. Again, there's a groove there, so we can then rotate and bury the knots. Aí dá para rodar os pontos, né? Para não ficar com possibilidade de extrusão no final.
But it's only one sulcus, or you have two different?
I had two in this case, one for the lens and one for the iris. It's a good point. It's one way to do it. And I think because you're passing the iris sutures, you can do with your money. I just thought that suturing a lens will be a little more stable. So I have another case, another surgery, and then I can talk a little bit about this implant. This was a very sad case. It's a 37-year-old female, had a ruptured globe. Ela teve trauma no olho. Na verdade, o filho que furou o olho dela com uma caneta. So the patient was struck in the left eye with a pen by the three-year-old son. She had history of LASIK, but she was hand motion in that eye. But she was able to refract, so the retina was working. And let me go straight here to the surgery. This is the case, very impressive. This is the right eye, and this is her left eye. So a disaster, right? So this is, we see a lot of these cases here end up coming to us here. And it was a big surgery, and I was like, how am I gonna do this case, right? But we order the artificial iris. Just to explain, the name is Human Optics. You take a picture of the good eye, goes to Germany, takes about 4 to 6 weeks, and they will paint that iris that matches the other eye. So, and then they will send the artificial iris. But in this case, I was thinking, you know, combining, I need a lens because the patient is aphakic, and I need an artificial iris at the same time. So how we're going to do that, right? We need in the transplant, because this cornea was all gone. So let's see here. That was a big case, and we're still working on her. She was, I think, a month. We have 4 weeks from this case, so it's brand new. 4 weeks. Let's see here. Well, this is what I was planning to do. Since that was open sky, I was like, I can just suture the lens behind the artificial iris implant to avoid 4 passes. Para evitar os 4 passes, eu vou suturar isso atrás dessa lente artificial. Let's see. So that was our plan there to, again, suture. I'm using 10-0 Prolene, but if you have 9-0 Prolene, it's even better. And this lens was just that big CZ70BD, a lente de PMMA da Alcon. And it's very hard to work when you're doing open sky surgery. So the plan was, again, to try to create all the cuts and the sulcus and everything before opening the eye. So again, that was 4 millimeters, is about 2.5 millimeters from the limbus. I'm creating a groove there, and I'm doing all my sclerotomies with the eye, before opening the eye. Because again, my main concern here, is how I would, just to work open sky. So then this is the transplant, and what I did, I just, trying to keep the eye closed as much as I could. So then before opening the cornea, I'm just using that cornea incision from the transplant to pass the sutures, to pass the vortex, right? So we have the entire iris bag lens complex, the iris IOL complex, and I'm passing the sutures there. And then you just implant everything. And this is what we have now. And then this residual iris, you can just use the vitractor. It was all necrotic tissue, necrose dessa íris, que ia ficar tocando a córnea. Then I just use the vitractor, to clean up, because I don't want that iris touching my new cornea. And then you just finish with a transplant, and then we'll see that at the end. So just finalizing, closing, and then I have here her. This was the intra-op picture, and this is one of the last time we saw this patient. So we still have some work to do, of course, with the sutures, she's doing good so far. Again, they're still working on the stigmatism. Well, I don't know, is this implant available in Brazil or not yet?
No.
No, yeah, it's interesting because again, it's a human optics. It's a posterior implant. It goes behind the iris, and it can be used in the bag, inside the capsular bag. Again, we do not recommend just placing in the sulcus because that can create some what we call the UG syndrome, but it's we can use, of course, for traumatic iris defects, atrophy, eye syndrome, and congenital anuria. And the main person that was the medical monitor in the US for this implant is Mike Schneider. I know Dani conhece o Mike Schneider bem, lá de Cincinnati. But he has, a lot of experience with artificial iris, so he is fantastic. But there's some contraindications, uveitis, dystrophies, right? Of course, diabetes, glaucoma, that you don't want to do that. So as I mentioned, you take picture of the other eye. This is handmade, which is so beautiful. Both the surgeon and the patients, we both need to accept the iris and agree with the color. So when you're taking the picture, actually they request a professional photographer to take a picture. So, in just normal light conditions, just to match. You don't need a lot here. I use regular tree finds. Ideally, if you have calipers that you can measure the sulcus during surgery, it's helpful, right? As we know, the white to white measurements do not correlate with the sulcus measurements. And that was a study of Liliana Werner. But usually how you calculate the size is the radius times 2 minus 0.5 millimeters. That's how we calculate the size. So average 9.5. If you're using white to white with the calipers, is minus 1 millimeters. You can use UBM or OCT. So, but this is again the study from Liliana Werner that she's, that there's no correlation between white to white and the ciliary sulcus. So intra-op is the best way that you can do to measure. But we try to look pre-op using OCT or UBM just to have an idea, so we can have the three finds available. So this is the injector that we use, so then you don't need to open the eye, right? Just using a small incision for the reconstruction. The Gore-Tex to suture. You can pre-suture the implant. Of course, is much easier passing the suture outside the eye than inside the eye, right? And with Gore-Tex, remember, it's 2-1-1-1 suture, because again, it's a thicker suture, and then you try to bury the knot. Você quer rodar, né, aquele ponto. Just showing that Gore-Tex is very safe for these cases, and it's better than Prolene, right? So it lasts longer. So I want to let Artur present the cases. We have 2 other cases here to present, but just showing, something that has been really great for these patients, those really dramatic patients that are aphakic, that had complicated cataract surgeries, and now they have iris defects. It's just an option. And sometimes the cerclage, the iris cerclage and the sutures, if you have a lot of atrophy, sometimes is really hard to do it.
Those were really, really great surgeries, Dr. Carlini, and congratulations. Beautiful, beautiful surgeries. And they are big surgeries, but there were so many small details that you showed us in your videos that make a huge, huge difference, like pre-suturing and opening the cornea as little as possible in the beginning. I mean, if anyone tries to do it otherwise, I believe that the results will be very far from what you could achieve. So really, congratulations. If anyone has any questions, we'll move on with Artur's presentation as well, but you can send it in the chat and we can open it for discussion after Artur's presentation. Dr. Wallace, you want to?
No, I just wanted to ask to our members if they have any information, if they're trying to apply for our FDA approval or visa approval or not. If anyone knows, if someone knows, please write down in the chat. So,
Artur, once again, thank you for participating as well. And please, you can start if you wish.
Good morning to all. I'm very pleased to participate in this meeting, and I would like to thank the organizer, particularly Dr. Taguchi. And it's also a pleasure to join Dr. Carol Maya here in this presentation with the University of South Carolina. In my participation, I will present 4 challenging surgeries. Here is the first one. This is a case of an extreme non-ophthalmic eye referred by a colleague from a city near Londrina. The patient was a 47-year-old male, and his main complaint was blindness in both eyes, noticed 6 months prior the consultation. He's a farmhand who stated never having worn glasses, despite the fact that he was never able to see properly. So we can conclude that he probably has amblyopic eyes. He had a history of laser iridotomy in both eyes, and his best corrected visual acuity was hand motion in both eyes, and both eyes with a small eye with very shallow anterior chamber, poor pupil dilation, laser iridotomy with iris atrophy around, and white cataract. The IOP was normal, 15 and 16, and the fundoscopy was not possible, but the US with attached retina and choroidal thickening. The first challenge in this case is the biometry. As shown, there was no consensus among the different formulas as expected in such a small eye. And I draw your attention to the axial length of 14.46, which shows a very small eye. The ACD of 1.7, defining a very shallow anterior chamber. LT 5.89, which is very thick for the size of the eye. And white to white 10.5. So the maximum diopter available in Brazil is Alcon SA60AT plus 40. And with this information in hand, we have 3 possible options here. One is primary piggyback IOL implantation. The second option is a secondary piggyback IOL. And the third option is implant the maximum diopter in the bag and then have the patient wear spectacles or contact lenses. Anyone wants to comment? Any comment? What would you do, Carol?
Artur, this is great. And when you told me you're talking about ophthalmos, I was just nervous because I remember a case, and of course it's a short eye, but all the structures, we have a resident here to learn, right? Everything is normal. So it's a very crowded eye, right? Has a big lens. The anterior chamber is extremely shallow. And I think even before the IOL, you're going to talk about surgery, but I run IV mannitol, and I had a case that we actually needed to do a vitrectomy decompression prior to surgery. And sometimes you need to do sclerotomy because they can have sclerofusion, right? Sclerofusion and a lot of complications. I like to follow Warren Hill for this to help us. He in his website gives step-by-step when you need to do a little piggyback, but I tend to put the max power of the lens in the bag. And then you just, if you have space for a sulcus lens, right? If you have space after surgery, to use a sulcus lens, then you can calculate the difference, but again, you're calculating that lens because, of course, the difference, you're placing that lens in the sulcus. It's still a high power lens. You follow all the vertex formula. And the formulas here are complicated. What's the best formula for this short eye, right? Is it Hill RBF, Barrett sometimes, if it's less than 19, I believe it doesn't calculate for you.
It doesn't calculate.
It doesn't calculate, right? So Hill RBF will give you a number, but shows a warning sign because it's out of boundary. Nobody knows for this short eyes with the newer formulas. We have an aura that after placing the first lens, I usually do a pseudophakic measurement that helps me a little bit. So you put up first lens and then you can use the aura to tell you the difference, just to double check that calculation. But again, I would, yeah, maximum power in the bag. And then if you have space, you can try a piggyback lens there. Let's see, what did you do? That's a hard case.
Okay. My option was the third one because I think is the safest with the fewest potential side effects. But I think there is no perfect answer. It's up to the surgeon's judgment, as you said. But believe me, there was no space for a piggyback IOL here. I've never seen such a small eye with 14 axial length is really shallow anterior chamber. The pre-op and the pre-op I prescribed 2 bottles of mannitol 30 minutes prior to the procedure. And let's take a look at the surgery. I'm performing this case under topical anesthesia with temporal approach because superiorly there was not enough space. Here comes the incision with a long tunnel to avoid iris prolapse. The mydriasis was not ideal, so I opted for the iris retractors due to the complexity of the case and the possibility of the worsening of the dilation during the procedure. Malugin ring is always my preferred option, but in this case, the anterior chamber was really shallow and it would be difficult to manipulate it. And more viscoelastic here to perform the Capsulorhexis. We have to keep pulling it toward the center to prevent it from radializing. There was a lot of positive pressure here. Then a smooth hydrodissection. And here comes the phaco probe. Chopping the nucleus in 2 halves. Then another fracture here. Separating those and bringing it to the iris plane to carefully emulsify. The cortex removal with bimanual irrigation aspiration. And finally, the IOL implant. Rotating the optic into the capsular bag. Removing iris retractors. Placing a suture in the main incision to avoid iris prolapse during the OVD removal. And then one more suture here in the paracentesis. So the case is completed. The first post-op patient extremely satisfied with the result. The uncorrected visual acuity was 2400, and in this slit lamp exam, eye redness 1+, corneal edema 1+, and a formed anterior chamber with well-centered IOL. That's the picture of the first post-op. And the fifth post-op, an uncorrected visual acuity of 2200. The best corrected visual acuity with this manifested refraction is 2100. A clear cornea, as you can see, the IOP 17. In the fundoscopy showed a crowded disc, which is a characteristic of an ophthalmic eye, and the macula was normal. As expected, we found an amblyopic eye, and his improvement with the refraction was minimal. But the patient regained his independence to do simple activities such as feeding himself, walking around, and most importantly, was able to return to his labor activities as he desired. Thank you. I don't know, Taguchi, if you want to discuss some points here, or should I present the second case?
First of all, I'd like to congratulate you on such a fantastic case. Once again, it looks, when we are watching your video, it looks like a normal surgery, but I mean, normal in the sense that you used iris retractors and you've done a superb technique, and that's what makes it look normal, because I am pretty sure it was a very hard surgery to perform, and that's what makes great surgeons. It looks easy in your hands. Well, I would ask you if you could present your second case, and then we'll take a break and discuss these four first cases, because I believe if we leave it all to the end, sometimes we get a little bit confused about what has already been presented. So please, Arthur.
Perfect. Let's go. This is another case. This is a case of a 67-year-old female complaining about decreased visual acuity in right eye. The patient had no recollection of any trauma in this eye, but this has most likely happened at some point of the past, as the other eye was completely normal in the slit lamp examination. Her best corrected visual acuity in the right eye was 20/80, and in the left eye, 20/30. The slit lamp examination showed a nuclear and posterior cortical cataract in both eyes, denser in the right eye, and the fundoscopy was normal in both eyes. This is the biometry. And we can see here at least 180 degrees temporal zonular weakness. The Capsulorhexis is being performed after the main incision with minimal evidence of zonular instability. Iris retractors are used on the Capsulorhexis edge to allow a safer procedure, followed by hydrodissection. Have to be very careful here. Placing the CTR. Then the nucleus is removed with phaco shop technique. At this point, the movements need to be very delicate to avoid any further lesions to the zonula. An important issue here in this case is always fill the anterior chamber with OVD before removing the phaco tip to avoid vitreous prolapse. And now proceeding the irrigation aspiration. As I finished the cortex removal, I noticed that the CTR was not in the correct position. So I adjusted without further problems. We can see here in the video, the Capsulorhexis was strange. Now removing the hooks and implanting the IOL. And as you can see, one haptic is placed along the area of zonular weakness. This haptic will exert an outward force which will support the capsular bag equator and help keep the optic centered. This results in a well-centered optic. Carbachol is instilled and OVD is removed from the anterior chamber using BSS. In theory, in these cases with 180 degrees of zonular dehiscence, we would have to fix the capsular bag with the appropriate device. In this specific case, it was possible to obtain a positive result at the end of the surgery without fixation. And during the Capsulorhexis, I could feel the stability of the crystalline, which pointed to a healthy zonula in the other areas. So it was not necessary, the scleral fixation. The slit lamp exam a clear cornea around pupil, and in the 7th post-operatory, patient satisfied with the result with 20/25 best corrected visual acuity, and this is the IOL and the 7th post-op. We can see a well-centered IOL, and that's the end of the case.
Once again, great, Arthur. Thank you very much, and congratulations for your beautiful, beautiful case in surgery. Very well performed. And well, let's open it for discussion a little bit while the audience gets ready to talk, because once again, I invite you, for everyone who has been writing down in the chat, please feel free to open your audio and state the questions as well. And this, because late is better than ever, I just noticed I haven't introduced properly our guests today. So Dr. Caroline Maya, she completed her formation in ophthalmology here in Brazil, and then she started her career in the US. She has done her fellowship in the Cleveland Clinic Foundation, and later her second residency, and now she's currently the director of the Cornea and Refractive Surgery Division at the Storm Eye Institute. And Dr. Arthur, he's from Paraná, Londrina, and he completed his residency here in Santa Casa, and he's also done his fellowship in glaucoma. And I would like to point out, as Dr. Wallace has already picked up this trait, that it's really a secret meeting from the surgeons from Paraná, Londrina, and we can see they are all brilliant. So congratulations to you both. And
yeah, I'm from Londrina, Paraná. Arthur is in my hometown.
Yes, Carol is my neighbor.
Now, Carol, tell your fellows how big Londrina is, because you know they can. Right? There are like 20 million people. How many?
No, how is Londrina now, Arthur? He may know. He can give
600,000.
600,000. I'm glad Arthur is there. He's doing such a great job. I'm really glad that he's, doing a fantastic job with cataract and everything that he's doing is a great job. This is a great case, Arthur. I think the comments are all right. Sometimes I have with me those Ahmed segments, because if I have any questions about centration, I just again use a little scleral tunnel, and of course Canabravo, Sergio, right? He taught us to use a haptic, right? That you can just create a flange in an IOL haptic, a PMMA haptic, or sometimes even easier, you can just use a 5-0 Prolene. Get the AMED segment, and then you cauterize one side of the Prolene. You can pass inside the eye with microforceps and just pull and just cauterize. You don't even need to pass the sutures and tight, right? It will be that having that Prolene, we call here the belt loop, that you can just use instead of a haptic, or just a little piece of Prolene, just an idea. You just go 2.5 millimeters from the limbus. And there was recently a call with Ike Ahmed, because I was doing 2, and then he suggested about 2.5 based on endoscopy. When you look, right, in the anatomy, he suggests 2.5. And then if you need, right, to use an AMEG segment in this cases, you can just use a needle, in that area, pass a needle at 2.5 millimeters, and then you feed the needle with this piece of Prolene, right, that go through actually you can even pass the suture and the segment before implanting inside the eye. Is then easier, and then you can just feed that needle, come out and cauterize. I think that is very efficient. Then you don't need to suture, open the conj or anything, the conjunctiva. But those cases are definitely challenging, and you handle really, really well. It's great.
Yes, I think in surgical planning for this kind of patient with clinically evident zonulopathy, it is important to plan for all possible situations that may arise intraoperatively. And this includes having all the tools and hardware potentially required available in the OR at the time of the surgery, as capsular hooks, iris hooks, CTR, Sione ring, or Ahmed tension segment, when scleral fixation being necessary. But it's also important to identify the etiology of the zonular defect, as trauma, zonular disease, or dysgenesis. I think it will help to perform the surgery better. But Ahmed tension segment is not available to buy here in Brazil. But when we go to ACRS, we can buy a lot of them and keep with us here.
About these, I believe, devices that we can use, Carol showed us a very interesting iris, or artificial iris. And does the human optics have FDA approval, or is it under a clinical trial or something like that?
FDA approval now, FDA approval. And just about costs, Felipe, and for everybody to know, initially it was so expensive, like $7,000 to $8,000 just the implant. But now this last case that I presented that we just did was covered by Medicare. Medicare is paying for it. Yes, it's amazing.
But only on older patients, right? For older patients.
She's young, actually. No, it was Medicaid. It was approved by her insurance. It was approved by our insurance. We wrote some letters. So then now, because I think it goes through like rare diseases, rare disorder, and then they can get funding. It's very similar to, I think, the oxervate, that drug for neurotrophic keratitis, because it's a rare disorder. So then we can, so this is good, it can definitely, some patients, it can definitely benefit from that, and patients that we, again, have no other options.
And I remember I presented once a grand round about it, and Dr. Walton, who unfortunately I think is not here, but here in Brazil, we may have some bad experience with artificial iris implants, but those that were maybe the first ones, and also the not so well indicated, I mean, the cosmetic iris implants. I don't know if you have experience with it. The new color iris or bright ocular, they're all like maybe on the dark side of this spectrum, but my question is, are those also suitable for implant in the sulcus, for example?
Yeah, no, good question. I mean, I remember seeing actually some cases in Brazil that implant, I think from Panama, right, was on top of the iris. And that was, of course, we know it's a problem because patients, they lose endothelial cells, they present with bullous keratopathy, corneal edema, and a lot of complications. That is a good question. You know, I don't know. I really am not familiar with the device. And I don't know if you can suture, you know, behind the iris, right? And the biocompatibility, se é biocompatível para ser suturado atrás da íris ou na câmara posterior.
But those were not human optics, right, Carol?
They're not human. No. Again, that was designed, you know, if you combine with cataract surgery, you can place in the bag, you put an IOL and you can place the iris in the bag. Or if the patient has, you know, pseudophakic or has the sulcus or aphakic, again, behind the iris plane with a suture, with scleral fixation.
Great. And for Arthur, would you consider performing the surgery that you've done under general anesthesia on the non-ophthalmic eye? Because we had a discussion in our group, I believe last week, and Dr. I don't remember now who was the surgeon, but we discussed many possibilities about doing mannitol and Jamox also. Some would do also clonidine. And what do you think? Were those also options for your surgery?
That's a good question. I think general anesthesia is certainly an excellent option due to the high complexity of the case and the risk of complication, such as IOP increase and explosive hemorrhage. I opted for topical anesthesia and sedation because I have done the same in similar cases with good results. But in this specific case, the patient wasn't very cooperative, and I have already chosen to do the second eye under general anesthesia. I think it's a better idea here. The case was nice, the case was good, but I think general anesthesia is safer. Yeah.
And about your second case, I believe it has already been discussed, but what always brings the question of when to use, I mean, when in the intraoperative do you implant the CTR? Neto usually says that you should implant it as late as you can and as long as you need it. What do you think? Do you usually pass it like you did in that case as soon as you're able to put it on the bag, like before doing the phaco itself?
I usually decided during the surgery, as I said, during the Capsulorhexis. In this case, I could feel stability of the crystalline, and which pointed to a healthy zone in other areas. But in some cases, I placed the CTR in the end before the IOL implant. But in this specific case, I prefer to place it before the phaco emulsification. But I think there is no right or wrong here. In the irrigation aspiration, the cortex irrigation aspiration, sometimes the CTR doesn't help and the cortex stays stuck. But in this case, it was really really, the case was fine here. There was no problem in the cortex aspiration here, but I think there is no right or wrong here.
Great. What about our audience? Do you have any questions? Just so as we can plan ourselves for the next half hour, I believe we could switch back to the US colleagues and present the third and fourth case from Musk, and then Arthur comes back and presents his last two cases as well. But before that, audience, questions? Anyone, comments? Okay, so let's move on.
Great. I'll ask James, Dr. Landreneau, who's going to take over. So James, he came to us. He's from University of Missouri. He's doing a great job. He started his fellowship in July, so he's new, but he's doing amazing, and he has done a lot of great cases already. James, he's actually he's going to go back and join the group there, and he'll be an assistant professor as soon as he's done with his fellowship, so which is great. So he has a job already, he's ready to go, so we need to keep him busy here, and we're really keeping him really busy here, which is great.
Hey, good morning, everyone. Thanks for inviting me to come talk this morning, and thanks, Dr. Rocha. Let me see if I can share. Okay, this first case was just a fun one that I'm not going to spend an overly long time on, but just more for discussion, just a couple of videos. The first case is called Hang In There, out of respect to the retina surgeon that we did a combined case on previously. And as I mentioned, I just want to say thanks to Dr. Rocha, Eduardo, who's the Cornea Research Fellow this year that helped with editing some of these videos. And then, of course, the resident that's currently in the cornea service, Dr. Levisi, that Dr. Rocha had mentioned earlier. Let me see if I can get
James, just a comment, James, when you show this video, you can tell them what happened to us this week, what happened this week.
Oh, yes, absolutely.
Okay.
Yeah. Yeah, let me see if I can. Eduardo, do you know how to hide this right here?
Go to more.
More. Hide.
Yeah.
Oh, wait. This right here. Okay. All right. Sorry, but here we go. So let me know if you can see this video. Just hit play. This is a patient who had a completely luxed IOL implant, acrylic implant. And the video has been edited to after the vitrectomy has already been performed by one of our retina surgeons. His name's Dr. Say. He had brought the single piece IOL up and had hung the haptic at the haptic optic junction onto the iris. I believe the patient was not under general anesthesia here. So his famous last words before handing this case over to Dr. Rocha was to quote unquote, hang in there, and to just have the patient be as still as possible before transferring hands to Dr. Rocha here. And as you can see, the previous trocar sites, the infusion line is out of the window here, but the patient still had infusion going during the next portion of this case as well. So, and here again is the IOL right before Dr. Rocha begins. The discussion point that I just wanted to stop for would be, what would be the next step if you had this kind of unbalanced IOL just kind of hanging there? What would you do next? And that's just going to open up to the general audience.
Arthur, what's your favorite technique when you have, this situations, or any surgeons, what you're comfortable doing? Because I always think the best technique is the one that it's going to work for you, right? That you can finish the case safely.
Dr. Landrino, could you please go back to your slide on the,
Here, I'll stop it. I'll stop the video.
Arthur, a lente estava, ele botou o áptico preso na íris e falou, tá bom, tchau. Me chama se cair de novo.
As you asked, I know you like it too, but my preferred fixation technique nowadays is Yamani. Okay, you have a 3-piece IOL, and it's very a quick technique when you perform. Sometimes it's not easy as it seems, but I think that's a really good technique to do this kind of case.
Great point. And I'll be honest, I learned iris suturing with Dr. Noza in Brazil. That's how I learned iris suturing IOL. My only question, I've always done with a 3-piece IOL. I don't think I've ever sutured a single piece, right, in the iris. But I'll let James finish the case and show what we did.
Yeah, I know Dr. Rocha and I have discussed this a little bit before. Just suturing a single piece IOL is challenging. There's a new tool that you can create a punch at the optic-haptic junction to suture through, similar to like an MX60 lens. But I talk for another day. So anyway, Dr. Say, who's the retina surgeon for this case, said, hang in there to the patient. And then it was transferred over to Dr. Rocha. This patient did have a Yamani, like Arthur had mentioned as his preferred approach. So the single piece IOL was explanted out of the eye. Just showing here, externalizing the haptic that was kind of hanging there. And what's not shown in the video is it was cut along the horizontal axis as the Pac-Man technique, and then sliding out the two halves, essentially. Here, inserting a 3-piece IOL with an assistant superior in this view, will be coming in with intraocular forceps. I'm going to pause the video for a second just to describe how the Yamani technique is done, at least at MUSC here. The horizontal axis is marked at the 180-degree axis. In this video, the surgeon is sitting superiorly. Over here is the temporal part of the eye. And this is where the assistant is coming in to grab the one of the haptics with a 30-gauge needle right here, or just I think it's 27-gauge needle. It's marked 2 millimeters away from the limbus, and then counterclockwise an additional 2 millimeters, and then with low temp cautery, just to create that bell and flange or ball and flange that's been described before in Yamani. So this patient did well, and just wanted to show kind of what we do often here at MUSC, which is combine cases with dislocated or completely luxed IOLs with the retina service. Just closing by putting a 10 nylon suture at the end. The main discussion that I wanted to talk about today, and something that I've been reading a lot about throughout my residency and now at the start of my fellowship, is determining what the most accurate IOL formula would be in challenging eyes. I know Arthur had mentioned that he, had spent a lot of time looking at that incredibly short ophthalmic eye. This is a case that we're going to be discussing about what lens formula to use in patients with keratoconus or status post penetrating keratoplasty. So Dr. Rocha's 4 S's when considering the cornea is the shape of the cornea, the structure, the strength, and then the sight that comes from. Let me move this out of the way. That comes out of specifically the corneal apex. This is a paper that described looking at different ways to take keratometry in the office. They compared 5 different devices. Those 5 were the Penacam, the ISIS Placido topographer, the orb scan, the IOL master, and then using manual keratometry with a Hog Street manual keratometer. They found in this particular study, so they did 3 scans each on all 5 of these devices in keratoconus patients. They stratified the groups into patients that had max K of less than 50 diopters in the first column, into group 2, which is max K 50 to 55 diopters, and then and finally group 3, which would be considered advanced or unstable keratoconus patients, having a max K of greater than 55 diopters. And they found in this study the test that had the highest amount of repeatability in accuracy for measuring both the maximum K and minimum K was the pentacam measurement using Schlenflung imaging to take into account the posterior corneal contribution of the corneal power that's affected by, especially in keratoconus patients, the posterior K. And as we know, in keratoconus patients, it's challenging to determine the intraocular lens implant that we use. A lot of the theoretical formulas in the past, and also the regression-based formulas, take into an assumption that there's a fixed ratio between the anterior and posterior corneal power. But as we know, that's not the case in keratoconus patients. Biometry in keratoconus typically overestimates the power of the cornea, and then thus underestimates the power of the IOL, thus leading to a hyperopic surprise in several of these patients. And IOL formulas typically use the corneal power to estimate the lens position of the IOL. So in these patients, if there's an error in K power, that leads to a effective error in the measurement for the effective lens position. And a lot of the papers that have determined what is the best, IOL calculation or a calculator for determining what would be the most accurate IOL implant, they've made some adjustments. The Holiday 2 comes with the keratoconus adjustment. I'll get to that in a little bit. It's been shown to be not that effective, actually. The 3 formulas that have shown to have the highest accuracy in keratoconus patients are the Barrett True K formula, which also takes into account the posterior corneal contribution, the Kane keratoconus formula, and then the 3rd generation SRKT theoretical / regression-based formula, which all make adjustments onto the overall corneal power to readjust where the effective lens position will be for the IOL implant. So this is a portion that I revised of a previous talk, discussed as the battle of the calculators. So this is a patient that I did surgery on. Is one actually of my first cases here at MUSC. It was a patient that had previously had penetrating keratoplasty in 2016 for advanced keratoconus. She had tried, after all the sutures were removed, using a RGP lens, scleral contact lens, and had difficulty with hard contacts. And over the past 5 years, eventually ended up developing a significant posterior sclerotic cataract just from prolonged steroid use and overall inflammation from previous surgery. So her MRX, or manifest refraction, prior to surgery, her right eye also had keratoconus, not as advanced as the left. -5 diopter measurement. She was able to see 20/20 with correction, with corrective eyeglasses. And then in the left eye, the eye that had previously had a penetrating keratoplasty, very high myopic eye, and a high amount of cylinder. And with glasses, her best corrected vision was around the 20/80, 2100 line of vision. She had a significant posterior sclerotic cataract, which also contributing to her overall acuity. decrease here, and otherwise an unremarkable exam. This is her Penacam measurements in the preoperative suite. She had a total of 22 diopters of anterior corneal cylinder and about a 7 diopter posterior corneal contribution. So overall, the total amount of I guess cylinder that we were trying to treat was roughly in that low teens, 13 diopter range. And again, just highlighting this, very unique eye of having, 23 diopters of anterior corneal astigmatism is rather large. And for someone that can't tolerate a contact lens, our option was to do an IOL exchange. So this is the Kane keratoconus formula. The Kane keratoconus formula has been shown to be one of the more highly accurate formulas that we use in patients that have keratoconus or regular corneas, just again, because it takes into account the posterior contribution. The biggest concern, as I mentioned before, in a lot of these patients, is just the hyperopic surprise that we get for underestimating the IOL power. So in patients that have a high K, the Kane modifier is that to recommend patients that have a range of 48 diopters to 53 diopters to target a more myopic result. And then in a stepwise fashion, if they're around a 55 diopter patient, you're meant to aim myopic in these patients. So you want to aim myopic with the anticipation that you could have a hyperopic result. In this patient, we ended up using a power of 5 diopters with the maximum SIL here, which we used a ZCU 600 Johnson & Johnson toric lens. So this is the Kane formula showing to use a 5 diopter lens. The SRKT formula, which does not take into account the toric lens, called for about a 3 diopter or 2.5 diopter lens. And then the Barrett Universal was stuck in the middle, calling for about a 4 to 4.5 diopter lens for a plano target, distance target. This is the video that I spliced just to show, we use, again, this is a patient that had a previous corneal transplant, PKP, all the sutures have been removed. We used catalyst femtosecond laser here for disassembling the nucleus and making the initial Capsulorhexis. And I'm using a chop technique here just to, break up the lens. The catalyst laser is incredibly nice. It just helps reduce the amount of phaco power needed to take out the overall amount of lens. I'm still learning how to chop on it. As you can see here, I chopped essentially into, it's almost like a pseudo divide and conquer chop almost, but the lens came out very nicely and then did cortical cleanup. I'm speeding up the video here just to show where the lens ultimately was resting at the end here. So clean up cortex. We ended up putting a suture in this patient, just again to prevent post-op hypotony and keep the wound stable. And finally, we oriented the axis of this lens at the 170 degree axis as Kane had suggested. So we used Kane formula, 5 diopter maximum toric power Johnson & Johnson ZCU lens. And at the end here, I just took a quick photo of where the toric lens was resting at the end, right here. That's about 176 degrees. The patient is doing well. We just saw her a few days ago. She's still post-op week 3. She has a little bit of cell left over. And a quick MRX showed that she lost about 15 diopters of sphere, coming a little bit closer to a more manageable target for wearing glasses. She still has quite a bit of residual astigmatism, which we expected just because toric lenses, even with the max toric like we used, had quite a bit of SIL, but we're still waiting to get her final MRX in a couple of weeks from now. And just kind of wrapping up, I just briefly wanted to talk about all the studies that have shown kind comparing all of the different lens calculations, the best formulas to use in patients with keratoconus or like a PKP, a high amount of cylinder, especially irregular cylinder, is surprisingly the SRK, the third generation SRK-T formula is comparable to about Kane in the Barrett Universal Toric. The SRK-T formula is nice because whenever we use this in patients that have high K, it actually leads to a more myopic result, which is nice in these patients because we end up oftentimes having a hyperopic result with the regression-based formulas. And there's a great paper that was published a few years ago in AAO, just showing again in these patients that have a high amount of anterior sill, with the SRK-T formula, it actually ends up being more myopic, but because a lot of these patients have a hyperopic result, that works in our favor. And this is another paper that was just published actually about 1.5 years ago in late 2019 by Dr. Kane, showing that the Kane keratoconus formula, the SRK-T, and the Barrett the Barrett TK formula had the highest accuracy in the predictive spherical equivalent at post-op 1 month. And again, just showing that the Barrett TK is also a suitable format for these patients. What I found surprising, just at the very end and kind of wrapping up here, is that we still have a long way to go with our formulas, even with the Kane formula, the SRK-T formula, and the Barrett TrueK formula. The overall results that we get with landing about a half diopter in either way, hyperopic or myopic of our target, is only about 50%, 60%. So I think we still have quite a bit to learn about these eyes, but whenever you compare that to some of the more theoretical formulas or third generation formulas in the past, their success rate of landing within that half diopter range is about 20 to 30%. So I think this patient had a good result overall. We will find out what her final refraction will be pretty soon. But I think overall for her spherical equivalent and tolerance to wearing glasses, she's much happier already at post-op week 3. That's all I have. I don't know if you all have any questions about, let me get out of this, about specific formulas. I kind of chopped a lot of this talk because I knew that we were spending just 15 minutes, but I can send these articles as well if you'd like to read them too.
James, really great job. I'll let Wallace comment, but it's interesting. I mean, we're definitely evolving, right? Because I remember the older publications, we kind of had nomograms for keratoconus to target minus according to the case. And then we've learned that SRK-T was a good formula for keratoconus, even better than Barrett's, right? But and it's interesting because if you look at that Malice paper, Jack Holliday group, he's a co-author. SRK-T is usually a really bad formula for steep case. They all end up myopic. So it's an error on the formula, but then it works for keratoconus, right? But and that was the idea, and it's a phenomenon of the formula. But then Kane, that changing that ratio and trying to better predict effective lens position, he developed that Kane KC formula that is definitely better than the regular Barrett. And this is all very recent. And then Barrett, he learned, of course, he spends at least 2-3 hours every week looking at calculations. It's unbelievable what he does. But then Barrett has that new formula, right? That is a Barrett TrueK TK. That TK is from the IOMaster 700, as you all know, that looks at anterior and posterior cornea. But I think, there was learning. We looked at every single formula, but as you can tell, it's a battle of the calculators because we see, in some cases, the lenses go from 5 to 15. And what would you do? I mean, just Wallace, we've been looking at KC so far here, but just want to learn from you now.
No, I'm sorry, you won't learn from me, Carol. But anyhow, I think there's some inherent errors on KC formulas are basically based on when you assume the posterior curvature of a cornea. So I presented last year, I believe, at the American Academy, a study showing that there is no correlation between the anterior and posterior curvature of the cornea in keratoconus, and that this error increases with the amount of the anterior or with the intensity of the keratoconus. So Felipe Taguchi and Rafael Kobayashi have guaranteed me that they would have now all the results of the updated data on that, but it seems that they don't have it yet. But anyhow, so I think the major problem on keratoconus is not the ELP, but the keratometry itself. So when we look at all those different formulas, what happens is sometimes, by chance, they correct ELPs and they correct it on the right direction and you have good results, but not always the basis of it is correct. So my first advice would be never use any keratometry that does not measure the posterior surface. You can't infer the posterior surface in keratoconus. And it applies especially for astigmatism. Because if you want to use the, if you want to know what is the astigmatism of that cornea, I'm sorry, you have to measure the posterior surface. And some of those formulas, they accept anterior surface only information. And if you have a very steep keratoconus, it won't work. But I promise you, or as a matter of fact, Kobayashi and Taguchi promise you that we will have this data on astigmatism on high and keratoconus in a month maximum. If not, they won't be here, okay? Taguchi can say something, or Kobayashi can say something about our data.
Coming soon, sir. I mean, yeah, we've been working with a large data set, and we basically analyzed the anterior-posterior surface relationship. And as Professor Wallace has already stated, it changes, and this disparity increases as we move on with more advanced keratoconus. And despite what Professor Wallace has said, I believe that it's also a matter of interpretation on how you consider the result is correct on these studies. Because like Dr. Chamon stated, on average, you may seem to be right, but the outliers are the problem in these cases. Sometimes you have very, very different results in similar patients. And although it may seem that these formulas have a nice correlation, it's not true for every patient. And that's why I believe Dr. Wallace advises to measure your patient, because when you infer the posterior surface, you're working with a population from where this data has been extracted, and that may not represent your patient. And it's interesting because Kane doesn't accept a posterior surface measurements, and that implies that they infer the posterior surface, and somehow they are correct in their assumptions, but it's still a black box, and so it's difficult to comment on it. Anyway, I'd like to please, Carol.
Can I ask? No, I think this is great points. I have a question for you, because first, how are you measuring the posterior cornea, the PCA? And I know it's complicated because, as far as I know, nothing can really give us that real measurement, right? But just your thoughts on, for example, if you're looking at the 700 that has the TK, or an OCT or Scheinflug? Just want to hear your thoughts there and what are you using for your study?
So, Carol, you're more than right. But you know, this is the conundrum of the posterior surface. Since nothing measures it accurately, we don't know who's measuring accurately. So we don't have a gold standard. There's no way to have a gold standard. So what we are using nowadays is Scheinflug. I mean, we don't have that many options to measure it. We have the Placido or the reflection. What's the name of it? Kazi. What's the name of the one that uses?
Cassini.
Cassini.
Yes, the Cassini.
LED.
We have never used it. I'm not sure if it's good or not. We have the Scheinflug. The OCT is still in the beginning, or we don't have a very good way to measure with OCT nowadays. So far, what we have is Scheinflug. We are using Scheinflug on this large data set. We're talking about more than 20 exams, 20,000 exams on that we are evaluating.
Wow. Just a thought, because I know Doug Koch, everything he published on the nomograms was Galilei was Scheinflug, right?
Yeah.
But even though a study will be just comparing all these devices in normal eyes and your abnormal eyes, maybe someone can publish and write a thesis there, because that is amazing. That is interesting.
There's only one way to check if the posterior surface is being measured accurately or not, which is very complicated. You can measure the anterior surface, operate the patient, implant a known IOL, and refract the patient. Then, with the known IOL, you can infer the posterior surface curvature or astigmatism. It's like patient has 4 diopters in the anterior surface. You place the 3 diopters IOL, astigmatism. We're talking about astigmatism now, okay? And the patient has a residual of 1.5. You can mathematically infer the posterior surface of the cornea. But this is very complicated. It depends on refraction. It's very complicated. I'm not aware of any study that has used this approach, but it's the only one so far. So we don't have good stuff.
And I'm just thinking here, because I had a webinar with Barrett when we had a Canadian meeting, and we had a case with an against the rule astigmatism. And as you know, the Baylor nomogram, there's a 20% that is off, right? Because again, it's Scheinflug measurements. And then we had 2 calculations, one using case and predicting the PCA with the Barrett formula, and then just using TK, right? And then Barrett, for that case, he's like, no, don't use TK, use the predicted. He said that the predicted was better. It was like, oh my gosh, and everybody loves TK now, right? The IO master with the total corneal power, because again, it was a huge difference in that against the rule astigmatismal case. But again, just to your point, I think there's a lot of things that we're better, but we can still fine tune with the.
We need more measurements, better measurements. I think Taguchi is on time now.
Yeah, I'm sorry to interrupt this fruitful discussion, but as we are ahead of time, I'll ask Arthur if he can present his last 2 cases, and I'd like to congratulate Dr. Landernau on his planning of those cases, because he showed us that planning is also important, and one case like planning in loco, and the other one planning well before the surgery. So Arthur?
This case relates to 51-year-old patient complaining of visual acuity decrease in both eyes with a bigger incidence in the left eye, lasting about 1 year. She had a history of high myopia and phakic IOL implantation with cachet IOL 8 years prior the consultation. The best corrected visual acuity in the right eye was 20/25, -2, and 20/30 in the left eye. In the prior biomicroscopy, we could see a well-placed cachet IOL, and we also found an initial cataract in the right eye and more advanced one in the left eye. Fundoscopy with no remarkable findings in both eyes. The patient desired to be spectacle independent after the surgery, so we decided to proceed to cachet explantation followed by phaco emulsification with Panoptix IOL implant and requested some pre-surgical exams. The specular microscopy, despite the fact that cachet IOL was discontinued due to possible endothelial cell loss, this patient presented a healthy cornea. The challenge in this case was caused by the biometry. We could see that the readings obtained in the exam were disproportional. ACD was underestimated considering a high myopia eye, and LT was overestimated considering a young cataract patient. And given the discrepancies of the data obtained in the exam, I decided to investigate better and found the error when I looked at this picture. The IOL master considered the cachet IOL instead of the anterior capsule in its readings. And when we visualize this picture, we can immediately notice that the corneal thickness seems to fit in the space between the IOL and the anterior chamber capsule 2 times. And having made this initial observation, I manually measured this space and confirmed it. Knowing that the corneal thickness was around 500 micrometers, we could calculate the space equivalent to 1000 micrometers or 1 millimeter. And this allowed me to make a new calculation of the lens by adjusting the measures of ACD and LT. And this generated an alteration of 0.5 diopters in the requested IOL. And when we consider a trifocal IOL implant in a high myopic eye, we have several variables to analyze in the biometry, so we should be as precise as possible to optimize the final result. All other complementary exams are normal. Let's take a look at the procedure. Sorry. Go back to the first here, the right eye. Using Callisto digital marker. After the incision, I proceed with the IOL explantation, splitting it in 2 just to facilitate the removal and minimize the aggression to the incision. The cataract surgery, as a usual procedure here, part of my routine, polishing the interior capsule and positioning the Panoptix toric IOL guided by Callisto. Here is the left eye. I perform the same procedure here, splitting the cachet in 2 parts, removing okay, sorry. In the post-op, we have a patient happy with the result with an uncorrected visual acuity of 20/25, Jagger 1. And so despite the difficulties found in the diagnostic phase, I managed to find the solution and culminated with a very satisfied patient. Can I
Arthur,
go
this
to the,
great case, Arthur, very nice.
okay, sorry. Okay, Taguchi?
Yeah, please, you call it.
Okay, the second case here, the fourth case actually, it's an IOL exchange case. This is a case of a 77-year-old female complaining of a large cloud in the right eye that she first noticed 1 year ago. She underwent an eventful phaco emulsification in both eyes 5 years prior and also had a history of macular degeneration. Actually, this patient went to 4 colleagues before this consultation. The first was a retinal specialist that was following her AMD, who recommended a vitrectomy and told her about the complexity of the case. And she got nervous and looked for other 3 opinions with local colleagues. 2 of them confirmed the need of vitrectomy, but the last one sent her to my clinic for evaluation. Her best corrected visual acuity in the right eye was 2200 and 2400 in the left eye. Slit lamp examination showed an IOL opacification in the right eye and a clear IOL in the left eye. Right eye fundoscopy was not possible to see details due to the IOL opacification and showed a DC-form scar in the left eye. It was difficult to evaluate the posterior capsule in the right eye, but fortunately there was no history of previous YAG laser capsulotomy. First, here, I think it's critical to ensure that the patient is comfortable. So in this case, I decided for a local block anesthesia. And the key step in the procedure is to find the space between the lens and the anterior capsule. And I usually use an insulin needle, as you can see. Now I'm trying to mobilize the IOL, but it was really difficult due to the fibrosis.
Arthur, why was the lens white again? I think I missed that. Por que que ficou opacificada desse jeito?
I don't know, Carol. It's a hydrophilic IOL, a Brazilian hydrophilic IOL, and we have some issues here with this kind of IOL here in Brazil. Unfortunately, it's not my first case. I have many cases like that, some cases like that with this kind of opacification after some years after the surgery.
Arthur, I've seen this before. I have not seen this specific lens in the United States, but I've seen a lot of videos of IOL exchanges similar to that. It's complete opacification, right? Even to the haptic.
Yes.
Yeah.
Yes,
you know what the deposits are that are on the lens, or what is going on with the lens itself?
I don't know why. I think Dr. Wallace, can you help me here with this question?
Why is it getting white to me?
The deposit in the lens.
I'm not sure. Carol may know, but I think it's calcium, right, Carol? I know it has
usually calcium, and I know, of course, it's Liliana's Werner work, right? She did so many work, sometimes can be related to gas in the eye or just the lens material, right? And the degradation over time, but it's usually calcium.
And I know has to do with the sterilization process. This specific IOL has to do with this. It's a hydrophilic IOL, and it has to do also with the sterilization process of the IOL.
Mm-hmm. because we see this case, we try to avoid hydrophilic, for example, if you're doing a DSEC, DMAC case, or someone that had retina surgery with gas.
We try to avoid it in humans in general.
Good one.
At this point here, sometimes we are able to rotate the lens within the bag, but in order to prevent trauma to the zonules, my option here was to remove only the optic and leave behind the haptics, because they were very adherent to the capsular bag. So I proceed the surgery cutting the first haptic near the incision, as you can see here. And then after the distal one, and now with the IOL in the anterior chamber, we are able to remove it relatively easily, splitting it into 2 pieces. During the optical removal, I inadvertently touched part of the rhexis, but fortunately I could fix it. The remaining haptics can interfere in the position of the new IOL, so I prefer to place a 3-piece IOL in the sulcus. No vitrectomy was required here. And then rotating it until found a stable position. Removing the OVD from the anterior chamber and then the case was completed. The patient was extremely happy with the result. The best corrected visual acuity was 20/50, and with round pupil and well-centered IOL. At the fundoscopy, there was macular atrophy compatible with dry AMD. There was a significant improvement in her visual acuity, and the day after surgery, the patient regained her independence of mobility, and it was her best and only functional eye. That is the end.
Great. Artur, I'd like to compliment you once again for your surgical expertise, and also for your ingenious solution for the first biometry case that you did. I'd like to ask our guests if they want to make any final remarks, because we are a little ahead of time. Of course, if you want to ask any final questions as well, please feel free. And I'll open up to Dr. Rocha and then Artur, please.
Just want to say thank you. Great seeing you all. I always learn something when we're together doing this. So thank you for having us. Wanting to, Eduardo, come and say hi next to James' camera. We can't see you because Eduardo is applying for a grant to go to Brazil He grew up here, but he's Brazilian. He's maybe gonna visit Leila in Manaus, may text you so he can come and visit you all. So he's applying for a federal grant actually to go to Brazil. But thank you so much for having us. Everybody have a great day, great cases.
Let us know, Eduardo. You're mostly welcome here.
Love to come see and work with you guys.
Arthur?
Thank you, everyone. It was a pleasure to be here with Carol, my neighbor from Londrina. And thank you, Taguchi, Dr. Wallace, and everyone for being here with us.
Congrats, Arthur and Carol. Nice to see you.
Ei, que saudade!
Maurício.
Beijão!
Valeu,
Abraço a
gente.
vocês.
Obrigado.
Bom trabalho, todo mundo!
Well, very, very appreciated to have everyone here, and also Dr. Landrino for presenting his case as well. Guys, really excellent. And once again, thank you all for audience. Also, please fill out our evaluation form. That's especially important for those in Brazil who are asking for their certificates. And well, have a nice weekend, a nice week. I'll just state these same things in Portuguese as well. Pessoal, não se esqueçam de preencher o nosso formulário de avaliação. Isso é especialmente importante para quem quer obter a presença ao final do nosso curso. Então, não se esqueçam, o código de hoje está no chat, o link também, por favor, fiquem à vontade. Pessoal, boa semana, muito obrigado a todos. Once again, thank you all, and bye-bye.
Thank you.
Valeu, gente. Tchau, tchau.
Oh, by the way, last remark. Next week we're going to have Professor Jod Mehta talking about fake IOLs. So if our colleagues in the US also are interested, please feel free to participate. Thank you all, guys.